Everyone excited? Yeah. Nothing like the last session around lunchtime. Perfect.
We're packing them in. We're packing them in.
All right, Anthony, why don't you kick us off?
So I am Anthony Laflan. I work at PointClickCare. And prior to coming to the company, I spent 13 years in the post-acute care world. I worked at marquee companies up in the Pacific Northwest. For those of you who don't know, that group has 37 buildings. At that point in time, they did. They've sold off a few, but spent time in operations, spent time in the pharmacy division and the rehab division. And toward the tail end of my career, I was able to build a platform that helped to unify all the data sets and became the backbone for our iSNP. We were one of the, I think we're the fourth iSNP, provider-led iSNP in the US, and came to PCC in 2020 as a part of an acquisition. So I'm going to introduce Danielle next.
Hi, my name is Danielle Salazar. I am the Assistant Director of the Post-Acute Network for Robert Wood Johnson Barnabas Health. I oversee the network for the entire health system. I also oversee our CJR program in conjunction with Brian George, who's one of our VPs. I'm a nurse by training, so many of my facilities I've worked with in my last 20-year career, where I began as a nurse. I also spent 5 years on the convener side at Remedy Partners, which is now Signify Health. I left that organization in 21 and came to Robert Wood Johnson. So I have the aspect of the SNF, the convener, as well as the health system.
And Danielle, why don't you tell us what you do on Fridays for fun?
I work every other weekend in a skilled nursing facility per diem still.
Woohoo! All right, well, clearly the talent is to my left. I'm here because I'm the CEO and founder of PointClickCare, so I get to kind of do whatever I like to do. And get the opportunity to work with Anthony and a bunch of fine folks. Half the room are people I get to work with. And the rest get to bitch at me. No, I'm kidding. This conference is really interesting, actually. It's the one conference that you get very direct feedback, and you generally require therapy after if you're a vendor. But you get to meet directly with operators and get the feedback you want to help me, drive a business forward and where we need to go. So this conversation today is a little bit about where we need to go and how we can connect better as partners with the other side, the evil side to my left. I'm kidding. We've had a great conversation preparing for this. So Anthony was going to be the moderator, and we're just going to go freewheel it a bit, and I may turn the script on him, and we'll have a little bit of fun, because why not? So back to you, Anthony.
Yeah, thank you, Dave. So no surprise there. Dave's going to surprise all of us with some questions for me. But I did prepare some questions around what's been happening in the last few years. And we wanted Danielle to participate today because she does have so many viewpoints, having worked both in post-acute as a convener and as a hospital system. I was honored to meet Danielle about 2 weeks ago. About 2 weeks ago, we were up in New Jersey, and we were able to successfully launch the Robert Wood Johnson system with a data sharing collaborative. And it's really laying the foundation for how we're going to unify the data sets between acute and post-acute so that the post-acute partners can become more accountable, more transparent, and maybe even playing a role in a risk-bearing world. So the COVID world has made life difficult, as we all know, especially for post-acute. I'd like to hear from Danielle's side what it's been like from the acute side of the house.
So through COVID, obviously, we weren't saved any more than the rest of you. Staffing has been a severe challenge through the entire continuum of care. So whether we see it at our health system, at our post-acute partners, or at our home care partners, staffing has posed challenges that impacts the quality and the delivery of care. So coming from the health system side, we work with our SNFs, and we get weekly updates on our patients that we have risk-bearing contracts on. So one of my thoughts was, how do we leverage technology to decrease the burden? So through COVID, the burden of staffing, and which has caused everyone challenges, leveraging technology to get those updates rather than having a live person pick up the phone and meet with my team weekly on how we're doing with our patients. So I think a post-COVID world, we have to be very innovative. We have to think outside the box. And when we look at our challenges, they may be the same challenges we've had for 5 years, but we now have those challenges with the stress of burden and burnout, even more so on our staffing than we did prior. So I think that's really one of the things that we're trying to do, is be innovative in how we work together with our post-acute partners.
Yeah, it was an exciting time, and I have to say, My favorite part of the day was the end when all the SNF operators came up and were congratulating us on being collaborative, being transparent, and making sure they earned a seat at the table to be a part of the network. So it was a great experience. Now, that's just one example. Dave, do you have any anecdotes for us about how COVID's impacted our client base? And maybe talk a little bit about our acquisitions and where your thought process was, where we were going.
Yeah, I don't need to talk to this room about how COVID impacted you. I think on the other side of it is really challenging. We have a lot of great partnerships. It was very emotional, but we recognized there was a need for information. And if you're not aware, we spent a lot of time with ACA, and we shared information around information that was necessary to help us kind of move through and represent. Mark Parkins didn't have a lot of data. He wasn't able to go to the Hill and talk effectively about what's happening. And with the information we were able to share with him, he was able to develop a point of view, and all the negative PR out there was tough to challenge. And so on leveraging that data, he was able to have, conversation about, why does COVID spread in a community? And it's not a bad operator, and it's not a private operator, and it's not all of these other reasons. So what the fundamental there was, digitizing matters, and if you hadn't been digitized or using some of the solutions, that information wouldn't be available to advocate. And so those simple things, kind of getting to that next point of what does that do for us as an organization, as I think about what you're looking for, step one is, how do I get information about the patients that I care about, right? Everybody, that's the one question everybody's looking to answer, right? Step one is, help me with that data. And we always talk about, sharing is caring, right? If we could all just have the same approach around sharing data, life would be a whole lot better. And so we spend so much time chasing information, and it's hard to get to. So as we talk about digitizing, the information we want to share and creating intelligence versus just monitoring, and I could go on and on about that, but I think what COVID has taught us is that having information and knowing how to leverage that to create intelligence and share that with your key collaborative partners makes a huge difference in the quality of care.
Well said. One of the things that I noticed at RWJ was in the wake of the launch, a number of SNF operators realized that notes are going to be shared with their hospital partners, to which Danielle, to your credit, you led off and said, listen, we're going to see all the information because these are our patients as well. And I think a lot of the angst that came up in that discussion was around the quality of information. A few of the SNF operators, they were in tune enough to say, well, wait a minute, I have temp staff that are putting notes into the system. I'm worried about the quality of information. Am I going to be held accountable to this? Danielle, talk a little bit about some of the things that you're hoping to achieve through this viewpoint of live data.
Sure. So being in the post-acute world prior, I understand that we always feel as though we're on the defense. So someone's always looking in and judging us and the care that we deliver daily. For my role at the hospital, at the health system, my role is not to tell you how to run your building or tell you how to care for my patients. My role is to collaborate with you all and increase that collaboration to have better outcomes for our patients. No one is going to be digging through notes. We have agency staff too, so we understand. But really what we're looking for is that kind of weekly update. So thinking outside the box, do we create a note, right? Called value-based care note, where once a week you enter that note in UR, and that's the only note we pull from you. Because believe me, my staff is stressed just as yours, and we're not looking to dig. I'm not looking to tell you all that you're being bad operators or that you're doing a bad job with our patients. I'm looking to see how can we do better to decrease the burden on both ends and then increase the quality outcomes for our patients. If the notes aren't there, we're still going to have to pick up the phone or send an email, and it's still going to leverage the burden, right? So if my team is reaching out and saying, hey, Mrs. Jones is there on day 10. Can you tell me how she's doing in therapy? Sure, Mrs. Jones did this. Okay, I also need to know the discharge plan and what VNA. If you don't answer what home care the patient's going, I now send another email back. Hey, what home care agency is the patient going to? If we have that access of looking in and seeing the social work note that the patient's being discharged with, Sunnyside home care, great. I already have that information, and it decreases the burden on my end as well as yours. And that's really what we're looking to do when we look for a solution to augment Episode Connect, which is what we had with our partners in our convener relationship.
Yeah, and I was struck by the narrative and how it came out because it reminded me of Summit. And Dave, I remember in the audience at Summit, you were explaining to the client base that we need to move away from everybody having their own version of a note or a way of doing things and unifying data. Lean in on that for us, Dave. Where are you going with that?
I think, end of the day, it's not about the operator, it's about the patient. And I think oftentimes we forget about that, and sharing information is truly, as you think about quality of care, I mean, I'm not a clinician, so bear with me, but I do believe that quality of care is directly related to the continuity of caregiver. And so an informed care provider, I use this example all the time. My grandmother was in a nursing home in Canada, it's a CNA, or a PSW versus a CNA, but they would go and they would grab the back of her calf, right? And she would scream out loud because she had so much pain as they put her in a wheelchair. All it took was sharing information with somebody caring for that person that would know, gosh, Joni doesn't like the back of her calf. I'm going to use the bottom of her foot. Small things like that have a massive impact in the quality of care, and I think that information just being available is huge. What I guess the next area I'd go to, so if we can have informed caregiving along the whole spectrum, I think about technology being an advocate. People get great care, kids get great care. Why? Because somebody really cares about their child and will advocate, right, life or death for them. There are so many individuals that are alone and don't have that support, and so I think technology can be a huge advocate. That means we have to participate and we have to share and we have to lean in and do the things that will have that impact. But one of the things that we struggle with, and I was going to ask you a bit about the trust side, it all makes sense to share data, but we have two issues, and I've wrote about this a number of times. Trust is a huge issue. Trusting what the other side is going to do with it. Are they going to use it to leverage it against me? Are they going to reduce my rates? Are they going to do something evil with it? And when we have the conversations, we have an ability for all of you to connect for free, I believe, Anthony, called PCC Connect. Now, I'd love to charge you for it, but actually by law, I don't think we can. So connect into national networks and actually improve transitions of care seems like a really good idea. We have spent the last 2 years calling customers to ask them to please just sign the data use agreement so you can share nationally with patients move across the continuum. We're not looking for anything but a consent to say, let us do it for you. Let us improve this patient's life, millions of them. And it's costing me so much time and effort to get your legal teams to go, oh, we're okay with that. And that is a huge barrier. So all of this makes sense, but somebody needs to spend time and recognize that there is value here in sharing data, and there are some real pitfalls and roadblocks that we struggle with to do the right thing.
And so if you think about that as a foundational step, and the fact of the presentation today is really around risk-bearing entities, which Danielle has done and is doing, how do you see post-acute providers and their data sharing playing a role in the risk-bearing world?
So back in the day when I was at Remedy, we had Model 3, which was a SNF risk-bearing bundle program. Our clients actually did very well in the program. One of the facilities in which we worked with actually leveraged PointClickCare to flag those patients, right? So they flagged the patient on admission so that when the patient was admitted to their unit, the staff knew, okay, this is one of the SNF's bundle patients. We triggered these protocols, and this is the care path for these patients. Now, the nurse in me is every patient should be treated the same. I always say the nurse at the bedside doesn't know that the patient has Medicare or Medicaid or whatever it is. We all care for them the same. However, when you build care paths, it heightens that awareness for your team. And for the SNF operators, they gained incentive payments for the good care in which they deliver to those patients. They were smart. They leveraged the technology. For us at the health system, we manage about 500,000 lives annually in risk-bearing contracts. We currently in 2023 are not in our bundle program. Our convener had pulled out, so we had to end that program. But in 2024, we're looking to go back in, right? So the whole world is risk-bearing, but we need you as much as you all need us in order to work together. So leveraging the technology, and you know where our health system is moving to Epic. Epic interfaces quite well with PointClickCare. So while we ask our post-acute partners to be transparent, we are looking to give that transparency back to you all and giving you access to your patient's chart through CareLink. So I think it's all about collaboration and how we work together. I think the person sitting in the chair has a lot to do with it. If someone different was in my role and they didn't understand the post-acute world, maybe our post-acute partners would feel differently about opening up their charts to us. So I think it really has to do with managing the relationship and how you leverage that when you're in risk-bearing contracts.
Yeah, it's pretty remarkable to see someone with Danielle's background in that seat because, as we all know, that's often not the case. And so when you talk about relationships that may not be as intuitive as RWJ, Dave, how do you see PointClickCare playing a role with sharing data in the risk-bearing world?
I think, you didn't talk about the number of buildings, but I think it was 85.
Yes.
Her buildings, I'm kidding. And a fair number of them are on our product, and so we're obviously trying to get the rest of them. What, 12 are not on yet? Poor Danielle. However, I think, as we talk about the risk-bearing world, I want to get into the models of care and the pathways in a moment, but the way we look at it, and I'd like you to speak to it after, Danielle, is the ability for you to differentiate is your ability to digitize and share more, right? And so as you think about the relationship that you want to have, is there's just not enough time or money to do the things that you might want to do without that information. And so it's about optimization and efficiency across the board. One of the things that we've spent a lot of time doing is invested in, I'll call it managed content. And so if you go back, we talk about this all the time, 10, 15 years, every customer we talked to, they were so proud about the protocols that they built, the assessments they put together, the links, the triggers, and they were better than Company X because they had their own clinicians building their own pathways. Today, nobody's fighting those pathways. They are like 1% different by community. So when you talk to Kaiser or you talk to Cleveland Clinic, or we talk, it's like for sepsis, pneumonia, CAUTI, the top 3 things they worry about, it's the same pathway. Now we fight about it. So if this patient goes here and they're coming from this company or coming from that company, the pathway you follow is the same way, but they're all looking for different things. And so when I think about risk-bearing entities, the ability to say, we're going to take this patient, here's the pathway we're following. We've agreed to this pathway. We're going to let you know electronically if they fall outside of this exception window, and you can deploy resources and help us versus monitor us. And so I think in those relationships, it's really about being clear on how you're going to care, leveraging standardized, clinical content, best practice, demonstrating that, and then leverage these resources more effectively to help you collaborate around patient care.
And I think, too, technology takes the person factor out of it, right? So whenever I meet with operators, we always talk about how processes shouldn't be people-driven. Because while Susie at Sunnyside Nursing Home is your star and she does everything, and I know I could pick up the phone and call her, and she's going to be like, don't worry, Danielle, I'm going to fix it. Susie doesn't work 24/7. So if you have process-driven, leveraged by your technology, your quality of care is less impacted by Susie, who not everyone is Susie, right? Some people, they do the best they can, they show up to work. But when you have that, you leverage the technology to implement those processes, it's simple. Us from the hospital system, we know, okay, if I send my patient over to Sunnyside Nursing Home, they have a CHF program. I've seen their pathways. Every single patient, regardless of where the patient comes from, is going to trigger that CHF pathway if that's their admitting diagnosis. So as a health system, we have a level of comfort that we can say we know our patient's going to have a good outcome when they come there because they have the processes in place, and you can do all that through leveraging your technology.
Well, so I want to wind the clock back a little bit for everybody in the audience. So how many of you have worked or run a building in the Pacific Northwest? I don't expect any hands to go up, but has anyone? What you may not know is that in that particular part of the country, even back in 2017, 8 out of 10 patients in our buildings were on a managed care stay. Think about that. In 2017, we were dealing with this. The managed care enrollment in that market is through the roof. That meant that my team and I had to deal with 8 different insurance providers with people rounding in the buildings, had their own approach to care, had their own negotiation tactics. And it fell on my shoulders as the head of the business intelligence department to go and negotiate with these payers. What I love about what we're talking about here is a unified standard approach that not only benefits the patient, but it benefits you, the business owner, because now you're in a position to collect data in a managed care world and speak their language. So I'll give you a great example of how this played out. In 2017, I went and met with probably the second largest health plan. And I sat across from the table very excited because that was when we made the leap to become a payer ourselves. You see, I began to realize that because Marquis was using unified data collection methodologies and care protocols, I could scrape information out of here and I could speak the same language as a health plan. And I understood this language because I was a health plan. So I knew what a HEDIS measure was. I understood the impact of antipsychotic use or reducing falls, all the things that go away from just utilization management. And so I went to that discussion super excited. It was myself and our owner. And we got our noses bloodied because they came to us and said, okay, we're going to try value-based care. If your 5-star rating on Nursing Home Compare is a 5-star, you get a 20% below Medicare PM or per patient per day reimbursement. If it's a 4-star, you get a 30% reduction. If it's a 3-star, you get a 40% reduction. Anything less than 3 stars, we're not going to contract with you. How disheartening is this? I'm sitting across from these two people, and they don't realize that the data set they're using isn't their patients. It's not even their members. They're using Medicare claims data to try and hold me accountable. They missed out on the opportunity for me to be able to articulate antipsychotic use or falls or even CAPS questions, the things that we were intuitively doing because we could understand that narrative. And these are all things that become a possibility in the future and things that I get very excited about. So Dave, I'd like to understand from you, if you could share with the group, where do you think the vision goes in terms of having contract negotiations with payers?
Well, I think you're the expert, let's be honest. I've never sat in a room negotiating payer contracts, but I will say, I'll talk a little bit about the vision where I think we'll go from a technology perspective, but what's clear to me in these value-based arrangements, it really is about managing cost. And I'd love to tell you we've moved to pay for performance. It is moving more dollars away from the bedside than we've seen in the past. And so that is a challenge to deliver on quality when dollars are coming out of the building. I think it's where we want to get to, and I think on a lot of those managed care discussions, there's an ability to think differently about how you get reimbursed. And it really needs to move into the conversation of pay for performance. So yes, we have these models that may not work perfectly. I think the desire is the right outcome we're looking for, but the reality is you have to be able to articulate how you're performing, and it has to make sense for the patient. So that's the other thing. You're a 5-star building. They send you, don't even like to use the word train wreck, but they send you one that takes you down to 4 stars. You're like, oh, tough luck on the reimbursement side. So you have to be able to have the conversation and really understand your data well. But I do think where it's ultimately going to land is there are going to be meaningful indicators that you will track with your partners, call it 3, 4, or 5. They're usually not all that different. Agree on what those outcomes look like, and you should be able to pay. We've seen many contracts that the customers get to, in some cases, north of 100% of an Advantage plan if they're performing at a certain level. Highly unusual. Most are on the other side of take this deal, it's 85%. If you don't go first, it's going to be 80 because I'm going to get somebody down the street. So it is a really interesting kind of tactic in terms of how you negotiate, but the reality is you should get paid for the quality you provide, and you should be able to create some leverage with your partners if you do it, but you have to have information to be able to have the conversation.
And I think, too, from our perspective, when I came from the convener side, there was so much focus on length of stay, right? Like SNFs, you need to get your length of stay down. Your CHF patient should have an 11 to 14-day length of stay. Well, let's be honest, not every CHF patient is built the same. So I think we really are looking in our health system and trying to move away from the conversation of length of stay and focusing on length of need. So when we have the length of need for the appropriate patient, the care is delivered appropriately to the patient, they have the best outcomes. So the CHF patient may have an 11-day length of stay, where another one may have a 30-day length of stay, but both of them are staying out of the hospital because the care in which you delivered at your facility was the appropriate care for that specific patient. So I think we really need to take a step back and look at how we look at these risk-bearing entities and contracts, and how do we work together to ensure that the patients have good outcomes and that the patients have the appropriate length of need for the care in which they need delivered at your facilities.
I think, yeah, so adding to that, because I think that's a really important component, length of need. I think the holy grail that we think about is how, as somebody discharges out of a hospital setting, what is the right number of days by setting to get to the right outcome, right? And that, we have data, we have millions of records, we're moving through it, and the ability to kind of have that. So as we talk about vision, yes, transitions are easy, you can figure that out. We can do MedRec, I mean, that's technology is available today. It's a lot easier than you think to get that information and really help your team out on transition. And gaps of care is obviously where we're very focused. But then I think it is, how do we, the thing that's missing is the ability to do collaboration outside the walls. Now, nursing homes are actually way more advanced than hospitals in so many ways, in that most of the services you use come from outside the building. So you're actually more integrated. It's much more challenging to do that than in a hospital setting because they control it all. And so now that you've done that, that next step of now collaborating, so when I think about the vision, yes, models of care, yes, pathways, all of that, but the ability for you to reach out to Susie, to have that collaborative kind of communication. So right now you're probably doing that with your docs, kind of asynchronous communications. Get a conversation going about a patient when maybe their length of needs to be extended, or there's a risk or something happens, to have a conversation with who's on the floor at that time. How many times have you picked up the phone and got somebody within seconds? Almost never, right?
Yes.
I mean, it's hard enough calling on a family member, never mind trying to coordinate care and then get the physician and the pharmacy involved to kind of resolve kind of what you're looking for. And so we believe that kind of the future is really connecting that ecosystem around the care for that patient, having that information come to life, and then having the conversation that allow you to intervene in those vulnerable moments that are the most costly in terms of the quality of life for the individual and the outcomes we're trying to strive for.
Absolutely, and sorry, Anthony. I think that from our perspective, we had a situation yesterday. Patient was discharged to the facility on Sunday. Yesterday, patient's back in the ED, and they're like, well, the SNF said they couldn't care for the patient. I'm like, what do you mean they couldn't care for the patient? So they call me. I go into my PointClickCare, and I look, and I see, well, the patient had a type of, it's called the Dubhoff tube, but it's a tube that not necessarily is cared for in most facilities. So when they accepted the patient, whoever accepted that patient wasn't aware that they couldn't care for that. So immediately the patient returns to the ED, and the hospital thinks, oh my God, like they couldn't even care for this patient for 24 hours. Like, how could we send our patients there? So I was able to go in and see actually what happened with the patient that led them back to the acute care stay, which deleted 5 different phone calls to me trying to reach the DON, the administrator, the corporate leadership, the owner, whoever I needed to get the answer. I was able to see it right there in the note from the facility that showed that the patient actually had a decline in their blood pressure and their respirations, and it actually had nothing to do with the tube. So that misconception right there was able to be solved in minutes. From Newark Airport as I was flying here yesterday. But that's not something I would have been able to do 2 weeks ago before we launched. It would have been me calling, and some of you here in the room know you received my phone call on the other end, but it would have been multiple phone calls to try to get to the right person to get the story. And at that point, it then could escalate to the leadership at the hospital wondering, well, what really happened at that facility? How can we send patients there if they can't even take care of this? So I think that leveraging the technology right there had helped to avoid that misconception for our post-acute partners that are doing great care for our patients.
And for context, what Danielle's describing is a new interface that we've launched that allows a hospital to see live data for their patients while they're still in the care setting, so they can actually have these narratives. And now that you have this really cool tool, what does the world look like in the next few years? Where are you going with this? Both of you.
So for us, for a health system, we looked at multiple platforms when we were notified that we would be losing our platform that we currently use. Real-time data is so important. You don't want me to come to your facility and talk to you about something that was done 2 years ago because your staff has turned over 3 times, and maybe the owner did too. So we're trying to give you real-time data to be able to impact your processes and improve the outcomes for our patients in real time. And we had that with Episode Connect, which was the platform we used through our convener. So when I looked at all the other platforms, the thing that PointClickCare is able to give us that others couldn't was that interoperability with our post-acute partners. For me, if I could have, my wish list, I would say us sharing data back and forth that when I discharge the patient from the hospital, the CCD, the med list, loads right into your EMR, so your nurse who's receiving the patient on the other end can confirm the meds with the doctor, but isn't taking 40 minutes to enter every single medication into your EMR. I think there's so much more that we can build from, and I think even in the few years that PointClickCare has built up this product, it's given us so much more than it would have given us 3 years ago.
Yeah, I was asked this a number of times here is, what's next for PointClickCare? And, when we feel like we have a responsibility, we have a significant market share, and we are cloud-based. So our ability to plug in once, we plug in the entire PointClickCare community, which has a huge impact on our ability to affect the patients that are part of that population set. And so as we look to the future, we were kind of battling out with some other companies, and it's like, great, we can do that. But the reality is the last mile problem is still a problem, and we could have done that, or we just, we leapfrogged 10 years and said, we're not going to compete, we're just going to go acquire. So we basically bought a couple of encounter notification services. Think of it as a notification service about clinical data across post-acute. So with those platforms, we're now able to bring kind of post-acute and acute care together. And we have, I think, density in 25 states. More than 50% of the hospitals are connected on our platform, never mind the national network. So the vision is we can bring these two worlds together. We can minimize kind of the gaps in care that exist today, have more informed care, and continue to drive not just where is my member and how are they doing, but let me know when I can do something about it so I can intervene when it matters the most and be a good partner. People are deploying a lot of resources, but not effectively. Those resources are being used to monitor and collect data and do things that really cause that burnout and don't feel like you're adding value. And so getting them deployed and doing things for those that are at most risk at that time, I think is where we have an opportunity to really change the world and invariably improve the patient's life and reduce costs at the same time and get towards the triple aim we've been trying for many years.
Well, I've asked a lot of questions. Dave, I know you prepped a few. I'm going to let you take the
I do.
ball.
So, yeah, I've got, we're going to go off piste here. So, Anthony, you've been doing this a while. We had the benefit of acquiring Anthony's company, basically, and Anthony came with, and we've retained him since. Super happy to have him. But what he does for us is really interesting. So maybe just explain what you've been doing lately, how you got connected here, and things that you're doing with providers, and some things they might want to think about in terms of how they can leverage us or others like you.
Yeah, so for those of you who don't know, I work on our acute and payer team, and I am the odd duck. And here's what I mean by that. I've never worked in a hospital. I've never worked, other than running an ISNP, I've never worked for Humana or United Healthcare, but I have worn your shoes, and I get it. And so the company was intuitive enough to put someone like me in this role so that I sit at the intersection between hospitals and post-acute providers. And they did this thoughtfully, primarily. I want to give Dave credit, but the reality is Travis actually gets most of the credit here. But they put me in this role because after the acquisition of Collective Medical and Audacious Inquiry, those ENS networks, they realized they had all of these hospitals that were now customers, but they didn't speak the same language. And they needed somebody to sit at that intersection and make sure that I'm being a good steward, much like Danielle does, someone who's worked in that experience and can blur the lines and connect the dots and pull data into PCC to speed up the med input process and increase accuracy. Ways to make sure that when we're articulating readmissions or length of stay, it's done around length of need and what's appropriate at the patient level. So that's really, as Travis calls it, my superpower, which I don't know if it's a superpower, but yeah.
But you're showing up today in hospitals with our customers.
Yeah,
right?
So hospitals call us and they're like, okay, you made the acquisition. We were already doing business with the prior company, but now you're owned by a long-term care EHR vendor. How do we get access to live data? And I'm always there to say, why do you want access? What's the goal? What are you trying to achieve? Because I want to make sure that it's done with the patient at the center of the narrative, making sure that we have a voice in the room that is talking the same language that you all speak, so the hospitals understand that it's not the same environment. It's very different, and they need to be cognizant of the challenges that we all deal with.
Excellent. And Danielle, maybe for you on the, how do you get in the network?
So the million-dollar question. Before I came to the health system, a lot of the evaluation of the network was based off of your CMS star ratings and how many patients we sent to you and how you did with those patients. For me, coming from the SNF side, I know that one surveyor that I have a bad survey can kill my star rating. So to look at an overall star rating, do we look at them? Yes, sure. But I leverage them at a different weight than your quality star rating. So your quality star rating is telling me how you're caring for the patients. So we look at your overall star rating, your quality star rating. We look at the volume of patients that we send you. We look, of course, at length of stay and readmissions. And then we also look at the engagement and the partnership. So I have a team of coordinators who follow the patients through the state when they're at the post-acute facility. So how is that collaboration? If we reach out to you, are you responding to us? I like to give everyone at least a week. On the second week that we send out another email, and if we don't hear, then I'll go to our next level contact. One, people go on vacation, and two, staffing changes. So we look at that. We try to give everyone every opportunity to ensure that our patients have choices, right? It's always patient choice. So if a patient asks for a skilled nursing facility that's not in our network, we absolutely send the patient where the patient wants to go. But the facilities in our network, the conversation is around, we have a partnership. We know we have good outcomes from our patients when they go to these facilities. And this is kind of the relationship in which we have when we're presenting the cases to our patients. So I always give an opportunity if a facility is out of network to meet with me. I will go out and tour the facility. I speak with their leadership, and we continue the conversation. So I evaluate the network every 6 months. It's kind of a constant evaluation. I work with the facilities very frequently, so I know often when challenges come up and arise. So, but every 6 months we put in the recommendation to our leaders as to the changes to our network. Sometimes it's more cuts than additions, but we want to make sure that our patients have good quality choices for where they're going.
I was just going to comment that I actually got to see this in real time. She's out in the hall earlier, and someone came up and said, "How come I'm not in the network?" And I just walked away. It was like, "Oh boy, it's going to get ugly."
Well, now I lost my train of thought. That's a good one. And we actually haven't talked about this, but I'm going to ask, with other customers, Anthony, and with your organization, as you think about the outcomes you're looking for as you kind of move forward with technology, what are you anticipating, and what are you seeing in others in terms of how they measure the investment they need to make, and what outcome are they looking for?
Sure. So I think we're always looking at return on investment. I am a clinician. I'm not a finance person. I tell everyone that. I'm a nurse, but I understand healthcare economics. And there has to be a return on investment, right? There's always, you're putting in so much money into something. How is it going to come back to you? And I think from an EMR perspective, I was a nurse in a nursing home when we were on paper, and we had our MARs and our TARs. But when you purchase the EMR in the way that it's meant to be utilized, so don't just purchase this part or this part, because if you don't purchase all of it, you're not going to get the full benefit. But I think when you look at how it's going to assist your staff, decreasing burnout, increase employee retention, and then of course leverage those relationships with your hospital partners, your referral sources, the return on investment is there. So sometimes you have to step outside the box and think, how can I do what's best for my organization as a whole and still ensure that the return is coming back to me? Because at the end of the day, it is a business that you need to be mindful of.
Yeah, for myself, I'm noticing that many of our customers come to us and are excited about the ability to share data because they realize that maybe in their state, Medicaid hasn't had a rate increase in a certain number of years, or certain health plans are really being bad actors in the way that they're being punitive in the way they go about negotiating. And so they're beginning to realize that by being collaborative and by learning to speak that other language and hold themselves accountable, by using live data, they actually can position themselves to win and to do better financially. So that's probably one of the biggest changes I've noticed in the last 18 months, people beginning to understand the value of collaboration and what it really could mean for them.
And I would say, too, from our partners who are very collaborative and who work very closely with us and are open to new ideas, the quality care that the patient gets is so much higher than other facilities that may not make the investment because whatever way they see it, but the quality comes with that, because when you increase and leverage technology, you're taking out the human error factor, right? So like I talked about my dream world of being the nurse on the other side, receiving that admission and being able to just confirm the orders rather than having to take 45 minutes to manually enter them. I think that shows the quality, and that'll take out the human, right? Less med errors decreases the return to hospitalization and overall a better quality care for our patients. So we never want to forget the quality side of the technology as well.
Yeah, I agree. And I think, we talk about these risk-based models, and it's clear to us on the other side that if you're going to be successful in the future, you either need to be a risk-bearing entity or you need to partner heavily with one. That's where the money is. That's where the money is going. And if you don't kind of think like they do or become one, I think you're going to struggle. You can't sustain the business you have with old models, right? Fee for service is not the future. And I think, the technology we have and the way we think about data is very much about think of yourself as that risk-bearing entity and what would you do? And a lot of that is, moving information, get what you can, share with those around you. So if you think about, whole patient, you're more inclined to do things that are incented around what's the right thing to do versus what economic model are you chasing. And so I think it's going to be a challenge for the next 18 months or so as we deal with inflation and census issues and staffing issues and more staffing issues. And so with those precious resources that we have, we need to deploy and use them as effectively as possible, because there is just, we have a crisis coming, and that's, staffing and the cost of healthcare.
Yeah, I would add to that if I were in your shoes, I would be mindful of which health plans are gaining market share in your geographic regions. I find it interesting that many of us have a contract with UHC or Humana or whoever it may be, and we think that's the status quo. We're not keeping eyes on the marketing efforts and the growth of the enrollment files. So you need to be careful to make sure that you're contracting with the appropriate plans that are out there. And then really, I would encourage you to, when you go to these negotiations, don't just sign the agreement. Sit down with them, if for no other reason than to ask them, what are you trying to achieve? How can I help you? Because going at it and assuming it's length of stay or it's readmissions or things like that, you might often miss something that you're really good at. So for example, I had a health plan once that was really focused on wound care. And I took that back to our leadership, and we decided to actually take a facility and really staff it with a lot of wound care nurses. And guess what happened? Almost everybody coming out of the hospital systems with those diagnoses flew to this building. And I know many of you were like, whoa, wait a minute, you lost your shirts. We didn't. We did very well because that health plan saw us as being creative and forward-thinking, and they influenced the hospital systems to send more and more of their members to our overall building populations. So there are ancillary benefits that go beyond just the contract negotiations on a one-off basis. And just having that discussion and understanding the landscape is a key piece of this.
So maybe some parting thoughts? Getting close on time.
I would just say, when you come to the table, whether it's a payer or a convener or a health system sitting across from you, think about how it can work best for both of you. How do you collaborate to improve the care for your patients while also watching your reimbursement? And just be open-minded, because I know often we come to the table a little defensive, because on the post-acute side, we're always on the punitive side. We're always on the defense, because people are always trying to judge us in what we do every day. So I think you go to the table knowing the care and quality that you deliver at your facilities, and you're able to leverage that to work with some of these payers or their risk-bearing entities, and there's going to be incentive for you on the other side as well.
Yeah, for me, I'd say plan with the end goal in mind. And by that I mean, if you have large chains of facilities, make sure they're being good stewards of the way the data is going in. Do it in a unified and consistent manner, because the information coming out on the back end is gold. And if you're not being dutiful, you'll paint yourself into a corner because you didn't use the same type of note approach or the same type of documentation. So consistency of data is a key aspect to this.
Yeah, I think that's a really good point. You really, if you're not, everyone's entering data in a very unique way, and as a result of that, it's really challenging to understand and take that information and turn it into intelligence. And so getting the data in and the observation so we can understand it and we can leverage that in a different way is really important, and there's that kind of a pathway forward there. But I'll tell you, just as we close out, I think there's light in the tunnel, and it's not a train, let's hope. I think there is kind of some hope ahead. We're really working down a path where we believe there's so much benefit to advancing your digitization that we know it's very challenging to afford in this industry. My hope is we can convince payers in some way, shape, or form that if you invest in care pathways for our customers, if you become a payer, right, there's only so much blood out of that stone. Like there's nothing left. And so it's very hard to advance and do the things we want to do as an industry. And so we're pushing for meaningful use dollars in kind of a new term, and the hope that we can help this whole group advance with technology and not have to underwrite the cost of it. So trying to bring more payers to the table and do our part. And we're in those conversations every day and trying to help. But with that, I want to thank my guests. Actually, why don't you do that, Mr. Moderator, sir?
No, we both of us need to thank Danielle, because we're
100%.
in awe. She's fantastic, and she flew down for the conference today to speak to everybody. So thank you very much, Danielle.
Yeah, thank you, Danielle. That's it for us. Have a wonderful end to eCap, and thanks for your participation here.